Thank you very much. Thank you for the invitation. Thank you, Lynn. Very appreciated. Well, we go from congenital to elderly patients, so it's quite a jump. So I have nothing to declare, but a lot of bias. Of course, I'm an ECMO believer. I really think that we have a lot to do there, but what about the elderly patient? I think that as all of us, I mean, we know that elderly patients are increasing because life expectancy is increasing. And beside the life expectancy, I think that a lot of people have really a lot of expectation. So we are more and more confronted not only with the elderly patient, but with elderly patients who expect a lot from us. So what should we do? I think that we know that the more the life expectancy goes on, but the more we'll be confronted with a lot of patients with advanced heart disease. So this is not a real trivial problem, because treating a patient electively is one thing, but going to emergency, that's a totally different story. So what should we do? So first of all, just a brief overview about cardiac surgery, so standard conventional cardiac surgery in the elderly. So what do we know? Because this is something also interesting. If you go through the literature, you want to know what has been studied in elderly patients. Well, you will be quite, let's say, surprised in a negative way. There's not that much. And if you go through, you will see that you have some findings about the effect of aging or gender, about the immune system. And we all know that age impacts this system quite a lot. So actually, we know that age adds insult to the so-called, to say, CPB-related injury. But not only that, we know that also the SEERS is much worse in elderly patients. And we have also all the biological, which is the biology of our body, particularly microcirculation, is very much impaired in this patient. But what is very important, I think that a lot of you and surgeons and perfusionists and doctors, we know that we have a lot of hemodynamic instability in this patient because of maybe our drug therapy, because of many different factors and variables. But after all, we have these situation in the elderly. So we have more hemodynamic instability. We have to be confronted with the perfusion efficacy. As you know, we have a lot of peripheral vascular disease. We have a lot of problems related to aging, to atherosclerosis, and so forth. And we all know that these patients bleed more often. So this patient will be most likely be confronted with a lot of transfusion, and we all know that this is not good. But as Professor Smana said before, are we really doing the right thing? So are we sure that we are doing not that, I mean, they are not too aggressive? We are operating more and more elderly patients who maybe are not really suitable candidates for surgery. This is a nice paper about the outcome and costs, because this is another problem. I mean, resources are limited, and of course we have to know. And they made a most institutional analysis. Just to make it more, simpler, they, of course, look at their elderly population. You can see below on over 80 years. And they found that the elderly candidates, the elderly patients, have been submitted more often to more complex operation. They had more associated procedure, and they received longer CPB and aortic cross-clamping times. And we know that this is definitely strictly related to perioperative complications. They also look at the, so to say, complication perioperative. They show that this patient had more readmission after discharge. They had longer ICU stay, more major complication, not only more complication. Of course, they saw higher mortality. You can see here from 3.1% below 80 of years and 6.5. But they found something interesting. They didn't find more resource utilization of this patient, which is quite interesting. We, myself and other colleagues and friends, we made some sort of analysis. It was not really the same, but we also look at cost and cost effectiveness. So we wanted to look after surgery, so quite a long time after surgery, if these patients were really taking benefit of what we did. And you can see here, we studied almost 3,000 patients. This was published in the journal some years ago. And you can see that there was not so much difference between the two populations, so below and over 80 years. But what we found, of course, we found that some complications were more frequent in the very elderly patient population. But we found, as this morning was clearly stated by a nice presentation this morning, this patient had a lot of problems related to disorientation, delirium, and a lot of transfusion. But after all, what was important, again, also in our study, we found that the elderly patients were submitted to longer intubation time, to longer ICU stay, and after all, longer hospitalization time. And we also confirmed the early mortality was higher in these patients. But what we did, as I told you before, we tried to make a sort of comparison. Are we doing really the right thing? And we made a sort of a comparison between the cost and the quality of life of these patients after discharge. And you can see that if you look at the patient above 80 years, the cost-effectiveness ratio is absolutely against. And this was confirmed also by this sort of a quality ratio, so the quality efficacy code, that if you go above, if you take into consideration some sort of operation, you have really no cost efficacy benefit. So we have really to think about many times on what we are doing, if it's really necessary or not. So in our conclusion, we thought that cardiac surgery in patient, really in the very elderly patient, was not always cost effective, but not only in terms of cost, but in terms of quality of life afterwards. So we should take into consideration each time we are examining, we are considering a patient for surgery, particularly above 80 years of age. So after all, what do we know in this patient? Well, we know for sure that these patients are increasing. So we will be confronted more and more in our daily practice with this patient. So we have to consider carefully this situation. We know that this patient, because of more comorbidities, because of more heart and vascular disease, they will be also submitted to more complex surgery. As I showed you, they will have more complications, but not only minor complications, they will have more major complications. So this should be taken into consideration. Results are, of course, worse, but why? Is this due to extracorporeal circulation? Is this due just to age, just nothing else? And after all, do we really have very long-term data? As I showed you, we made a long-term, but just a few years, but we don't really have the full spectrum of information just to help us in the daily decision-making. So, in conclusion, for the extracorporeal circulation, so for daily patients, we have high morbidity, high mortality rates in elderly patients. So should we refuse them? I don't think we should have an age limit. Of course, the very, very elderly will have a very high mortality, very high rate of morbidity and complication. I think that after all, this is very trivial, maybe very too simplistic, but we are really to have a careful assessment and research for protective and minimally invasive approach. This morning was really well taken, the message. We have really to consider to be more protective, particularly in cardiopulmonary bypass. But what about ECMO? This is another very important setting, and why? I just show you this is a very recent publication from the Taiwan group in Circulation, and you can see that they examined more than 4,200 patients who were submitted to ECMO implant in Taipei. And they had a look to evaluate, of course, outcome, complication, and so forth. But look at this patient population. I mean, the patient above 70 years, which is considered elderly in many institutions, they are absolutely not considered for ECMO. Sometimes 65 is the age limit. But in this series, patients above 70 years constituted 25% of the total experience. So a very, very high number of patients. So, and you can see here the death within 60 days, 70 days, 7 days, within 30 days, you can see it's almost 60%. During hospitalization, 65, and within 1 year, 76%. And they look also at the age, and they took as a reference for age the group of patients between 65 and 74. And obviously, the patient younger than this group of this patient cohort had a better survival, but patients above 75 were not really doing so bad. I mean, of course, it was a risk factor for mortality, but it was not really a dramatic change or dramatically worse. But let's have a look about numbers, because this was a very, a huge number of patients, but and in Type A, but let's have a look in US. So the Stretch and colleagues, they had a look of the nationwide inpatient sample from the US, so they took almost 12,000 patients between 2004 and 2011. And you can clearly see here that they had a look at the mechanical circulatory support, so EIBP, short-term, non-percutaneous, short-term percutaneous, and ECMO. And you can clearly see that all but the short-term non-percutaneous had quite a substantial increase. But particularly, and this is the message, is that the percutaneous device increased more than 1,500% in the period between 2007 and 2011, whereas the non-percutaneous device increased only 100%. So this is definitely a setting which we will see more and more often in the coming years. But what about the age? So devices are increasing, the implant is increasing. You can see here from this study that the patients below 65, they had a change from the 2-year period actually in the decline. So they decline in the younger patient population. But quite surprisingly, you can see in the patient above 65, in the 2-year period, they both increase, either below 80, but particularly above 80. So mechanical circulatory support devices are considered more and more in the elderly than in the younger population, which for me was really surprising. This is another study, very important, almost 24,000 patients. And you can see again about the ECMO, only ECMO. So they look at the neurologic complication, but if you look at the number of patients, you see again the ECMO is definitely increasing, is really booming in all the patient population, so pediatric or adults. But if you look here at the demographic outcome, in this series, the patients above 65 were 8.3%. So not as frequent as the studies before, but still a substantial number of patients. And so what is the outcome? So we see that patients' number are increasing, the numbers are increasing, but what about the outcome in the elderly submitted to ECMO? This is a study from Mendiratta and colleagues from the ELSO registry. This was published in 2013. They had a look only at the elderly population. You can see that they confirm once again that this is definitely increasing. And you can see here total number, and the black bar and the gray bar are the patient who died. But if you look at the two cohorts, below 75 years of age and above 75 years of age, there was here the difference at hospitalization after ECMO support initiated. And you can see here the difference. But they look also at the duration of ECMO support between the two cohorts, and they didn't find any significant difference. So this is another interesting experience from the German experience. They look at VA and VA ECMO in all the patient age. And again, this was really surprising. You can see here that ECMO, after the SHOCK 2 trial, definitely and remarkably increased. But particularly, if you look at the patient above 70 years of age, you can see that it's quite a substantial number of patients. So also in Germany, so not only in Type A, not only in US, But also in Europe, we can see clearly that the elderly patients are more and more submitted to ECMO. But what about the difference, VA and VV? So you can see here the year of the study, and this is the in-hospital mortality, which was quite constant, so there was no major change along the years. But of course, if you look at the patient age, this is different. The more the patient are, of course, the older the patient and the worse the outcome. But if you look at the actual numbers, you don't see really a mortality rate which is unacceptable. The same thing was for VV ECMO. Again, this is a number, and you can see that in Germany, the number of VV ECMO looked a little bit to decline in the recent years. But again, if you take into consideration the elderly patient, this is quite a substantial number of patients. So again, also for VV ECMO, more and more elderly patients are considered for implant. What about the outcome? Again, mortality quite stable. And of course, as the older the patient, the worse the outcome. But again, not so dramatic to consider elderly patient really not suitable, not candidate for ECMO. This is another study of Mendirata, but this time for a patient in the health registry for respiratory, not only for ECPR as was before. And you can see here, booming again on the ECMO number, survivors and non-survivors, survivors gray bar. And the in-hospital survivor was 41% in VV ECMO as compared to 55% in the rest of the population. So again, I don't think we can consider 41% really an acceptable rate. Sorry. This was a study by Narodsky and colleagues from the Columbia, and they had a look about, again, the short and long-term results of patient submitted to ECMO. So again, does the age matter in this respect? And you can see here, sorry, they look either at the early or the long-term survival. But when they made a sort of equal comparison between the two cohorts of patients, they didn't see any difference between patients below 65 or above 65. And this was either for a hospital discharge or 1 year survival. After combining the comorbidity factors, the two cohorts were not different in survivals. This was another study from Osaka in Japan. Again, they look whether ECMO is contraindicated in elderly patients. They studied 91 patients, but what they saw is that 79 patients were below 75 and 12 above 75. This is a very small case series, but what they found that the weaning, so weaning from ECMO, in the two patient cohort was 63.3% in the, let's say, so to say, younger patient population and 50%. But if you look at the survival to discharge, the two patient cohort did not differ. So this is another quite interesting finding that the elderly group was, the outcome was equal to the younger patient population. This is another study from Melbourne, and they look again at the older patient population, 70 patients only, weaning 67%. A survival to hospital discharge was 41, almost the same as before. But looking at the postoperative quality of life, this is very interesting. All patient discharged, so all the patients were alive and well at follow-up with a median of 21 months. So this means that if the patient, the elderly patient submitted to ECMO survived the hospital period, after hospital discharge, the quality of life and the survival rate is quite good. This is quite another very, very recent study from the group of Melbourne again and Mayo Clinic in Rochester, and they look again at the elderly population and ECMO. You can see here the mortality and at the follow-up. But again, when they compare these results with a younger patient cohort, they didn't find a significant difference at long term. So what did they find, however, and this is interesting also for what we are doing that the elderly patients had a higher rate of multi-organ failure. So when they died, the cause of death was multi-organ failure. And this is, of course, rather obvious, but I think it's to be taken into consideration. So they are, of course, more fragile. So once they go into a crash situation, they have more rapidly and more likely to have a MOF, so a multi-organ failure. We made another study. So myself and my group, an international group, we look at the elderly patient submitted to ECMO for cardiogenic shock. And we studied more than 700 patients, 753, single VA ECMO for cardiogenic shock, and the mean age was 75.2. So we studied only patients above 70 years of age, and we compared this to a younger patient population. And you can see here that the mortality, so this is the total number of patients, the elderly patient, you can see here represented almost 15% of the total of the overall patient population of the ELSO registry, adult. And you can see here, this is the elderly and the survivors. The survivors was rather good in the, let's say, the year between 1999 and 2010. Then we had quite a decline in the last period of the study, but still is around 30%. So comparing the two patient cohort, you can see here that the survival in the elderly patient was the mean at 30.5% as compared to 43% of the younger patient population. But again, if you take the crude number, I think that this is really quite an acceptable rate. And what are the clues of these patients? This is also very interesting. More frequently, these patients had cardiac surgery before, or they had cardio-related procedure. You can see almost 19%, and 2.2 were post-cardiotomy patients as compared to 0.7 in the younger patient population. What does it mean? It means that more elderly patients had post-cardiotomy ECMO, so maybe this is considered more in this patient. As the study from the Mayo Clinic and Melbourne, we also found that these patients died more frequently for multi-organ failure. They had less ECMO duration, reduced ECMO duration, most likely because ECMO is stopped, of course, earlier than the younger patient population. And strangely and surprisingly, we found less system-related complication and acute renal failure. But this is mainly, we think, due to the fact that the elderly patients were submitted to a shorter ECMO duration. And this is what we found as a predictor. So could we select the patients for ECMO if they are elderly? So can we select patients with a more favorable, maybe, outcome? And this is what we found. We found a patient with inotropes in IBP and lower blood pressure before ECMO, or prolonged intubation to ECMO time, higher ECMO flow at 24 hours, and absence of protective ventilation during ECMO. And on ECMO, also the need of aggressive inotropic support, the bleeding, neurologic injury, metabolic impairment, kidney failure, and broad-proven infection were all factors, negative predictor for hospital survival. I just want to show you, I showed you this already in EuroELSO, but just to give you an example of a patient I had. This is an 80-year-old male, aortic dissection. He had the car accident because he had the dissection, and so he went against a tree. So not only aortic dissection, but he had diaphragm rupture, pulmonary contusion, and after the repair of the aortic dissection, he had a severe hemorrhage, pulmonary hemorrhage, and it was impossible to wean because of impossibility to mechanically ventilate. So I put on VA ECMO for 4 days and then 5 days in VV, and now it's almost 2 years of follow-up, and he's really doing fine. But this is an anecdote, of course, but just to say that we have the worst case scenario. So aortic dissection, a lot of people will say, oh, contraindication for ECMO. I think that after the repair, you can still do, but in 80 years, so is a good biological condition. He was in a good biological condition. I think this should not represent a contraindication. So in conclusion, I think that CPB and ECMO are now more and more considered in very elderly patients, and I think that The number is increasing, and this is for all elderly ages. I think we have to admit, of course, it's not question about higher complication and mortality rates. But this should not be the reason to exclude this patient for daily surgery or for ECMO. I think that the outcome is still respectable. Also in ECMO, we have to find the real contraindication. We are working on that, but still a long way to go. I think that, as you can imagine, either for daily surgery or for ECMO, patient selection is really critical to enhance outcome and, of course, to utilize in a better way our resources. I think that the interaction between surgeon and intensivist and perfusionist is really critical, and that's the reason why I think that for an optimal resource utilization in the future, I would propose that we should have a sort of an elderly heart team, because the elderly patient must be really screened and assessed so carefully. And I think that this team, perfusionist surgeons, anesthesiologists, and the ICU people may really make a very good group and discuss all the risks, all the benefits, all the advantages, and maybe the futility of some intervention. So just to conclude, I would wish to invite all of you for EuroELSO 2017, the sixth event in Maastricht, the Netherlands. I can assure you it will be a very interesting Congress with all the latest news about ECMO. Thank you very much.